Hi, everyone. Thank you for being here. My name is Kim Tuminello. I am the current Director of Advocacy for ACD, and I'm also a mom of both my children have Gant. My son was diagnosed in 2006. He was about 10 months old at the time, and he's gone through years of physical therapy, occupational therapy, speech therapy, visual horse therapy. We threw it all at him. And then my daughter was born in 2009, and she was treated since birth. And actually, I did an amniocentesis while I was pregnant with her, and actually took creatine while I was pregnant. She has never had a day of therapy. She's never had a delay, pretty typical kid. And so that really just kind of fueled my fire for newborn screening. So that's why I'm here today, along with all of you, and trying to find a better treatment, better resources, and so I'm really grateful to all of you for being here, because I know that you're all as passionate about this as we all are. So today I'm going to tell you about newborn screening, what our efforts are here at ACD, what our goals are, and let you know what our past, current, and future goals are. I'll also tell you a little bit about the process to try to get conditions added to the newborn screening. Our basic efforts are starting at the national level, but then we have to go to the state level too. So the National Newborn Screening Panel here in the U.S. is called the RUSP. And RUSP stands for the Recommended Uniform Screening Panel. The RUSP guides and supports the states and their individual and development of their own newborn screenings. So, here we go. What's that? Green arrow. Green arrow. Here we go. All right. So the RUSP, as I said, kind of sets the standards for the care and what the different states are going to be doing. So for ACD, our current focus is on GAMT and AGAT. This is because there is an FDA-approved treatment, which is required to be considered for the newborn screening. And of course, we're working with pharmaceutical companies to help find a treatment for CTD so that we can include that into our newborn screening efforts. Newborn screening programs differ from state to state, and certainly from country to country. Some states will include all of the disorders that are being recommended on the RUSP, and some don't. It is up to the individual state's Department of Health to determine what they will screen for. And depending on what their state's laws are, it will also determine how quickly they will add those disorders to their own panel. I've worked with the Every Life Foundation and going to state capitals to have them recommend this be done as soon as possible. California, where we're from, they kind of had an open-ended check. Once it's recommended on RUSP, they can wait, 6 months, 2 years, 10 years before they add it. Every Life Foundation is working to make sure that those states add that quickly, so within 6 months to 2 years. The RUSP establishes a standardized list of disorders that have been well vetted and voted by the Advisory Committee of Heritable Disorders in Newborns and Children, otherwise known as the ACH-DNC. And then it is signed off by the Secretary of the U.S. Department of Health and Human Services. To give you a little background on this committee, they meet quarterly in Bethesda, Maryland. It's just outside of Washington, D.C., and is made up of physicians and organizations that represent national public health constituencies, such as the CDC, and medical professional societies and consumer and family advocacy groups with a large involvement in newborn screening. So I'm going to talk a little bit about the RUSP criteria and what they're looking for. The conditions that are included today in newborn screening are those that would either cause a serious impairment or death if they are not given an early diagnosis and treatment. I want to give you a few statistics. I know I've had a chance to talk with some of you out there, but there are over 7,000 rare diseases. Of that 7,000, only 5% of those rare diseases have a treatment. 5%. That gives us 350 disorders that even have a treatment. Of those 350 conditions that have treatment, there are only 35 core conditions that are on the RUSP and 26 secondary, right? So we're at about 60 of those 350 treatable disorders. And I want to quickly explain a secondary condition, you guys have probably heard, is a core, after testing for a core condition, these secondary disorders can be detected coincidentally because of a confirmatory test and has an out-of-range result. So next up is the decision matrix. You're not going to probably be able to read this very well, so I'll give you a little hint of what it says. In general, the requirements are that there needs to be evidence that supports the potential net benefit of screening. The states need to have the ability to screen for the disorder, meaning that they have the testing equipment, the funding, the personnel to do it, the manpower, and that the health outcomes of the condition are well understood. There needs to be an available and effective treatment, and the identification of the condition could affect the future reproductive decisions of a family. And the newest criteria that we were met with, and I will explain this in a minute, is that there has been at least one confirmed newborn screen of the disorder either in an individual state or within another country. So, step-by-step process when we meet with ACHDNC about the RUSP. The first step is the committee's nomination and prioritization work group, and they reviewed a completed nomination package, which for Gant, Dr. Longo filled out for us, and a complete summary of the ACHDNC's consideration. The committee then decides to move it to a work group, and they decide if the evidence is sufficient, whether to assign or not to assign the nominated disorder to a condition review work group. Nominations to conditions are not assigned would be provided with feedback as to why they are not being moved forward. The condition is indeed moved forward to the condition review work group. They will complete a systematic, evidence-based review, provide updates, and present a report to the committee on the assigned disorder, which they did with Gant back in 2016. At the quarterly meeting, the advisory committee will discuss and deliberate on the evidence presented by the condition review work group on whether the disorder will be moved to the scientific evidence review committee. This is one of the most important meetings that a patient advocacy group can attend, either in person or by phone. We chose to go there personally, which the ACD Newborn Screening Committee did for the first time in the spring of 2016. If the committee votes the condition forward to the scientific review, the clock is ticking. They, at that point, have 9 months to review the condition and make a recommendation to the ACHDNC whether or not it should be considered to be added to the RUSP. And on a side note, it was said to us many times that if this gets moved to the evidence work group, that chances are you will be put on the RUSP. It's very, I don't know if it's ever been done where it's been moved forward and they didn't add it. So the final steps after the scientific review is done is the advisory committee votes once again and decides if they will recommend the disorder to be sent to the Secretary of Health and Human Services to be added to the RUSP. And finally, and the Secretary will sign on the nomination, and the nominators whose conditions are, again, not recommended would be given that feedback. So this is a slide of what we were met with. This is the night before, a picture of ACD's Newborn Screening Committee, our first presentation at RUSP at May of 2016. Laura Martin, Missy Clore, Heidi Wallace, and I, who all have Gant children. And this is actually Mother's Day. We had all flown out that morning because the meeting started that following Monday morning. And we all got to spend Mother's Day together, and I can tell you it felt pretty fitting, actually. Anyway, so on the morning that we were presenting on the agenda was a discussion and vote for the ACHDNC to add a new criteria to that decision matrix. That new criteria ended up being that for a condition to be added to the RUSP, there would have to be one true positive of a case of any disorder screened and caught during a newborn screen. So what did that mean for Gant? Unfortunately, because Gant is a rare condition and had never been caught on a newborn screen, that would disqualify us from moving forward for now. I'm going to tell you it was a fierce debate amongst the committee members. What was slated in the agenda for about 15 minutes probably lasted well over an hour. And the members of the committee argued that, with an ultra-rare disease like what we have, that it would be very difficult and time-consuming to find that one positive and how many babies would be missed in the meantime. And of course, that's our frustration. When the vote came down to Gant, we lost by one. I'm going to tell you, I'm still heartbroken. Along with the rest of the board, the committee, and probably all of you. But it didn't stop us. After that rest meeting, many of the ACHDNC committee members came up to us and said, "Do not give up. You are so close. You're closer than probably any of the other disorders we've ever seen." They said, "Go advocate in the different states." And we said, "Okay, we'll do that." So I'm going to tell you a little bit more about Gant. It's not considered just a rare disease. It's an ultra-rare disease, right? Which means our rate of occurrence is extremely low, which I know we've talked a little bit about today. 1 out of 250,000, maybe, possibly a million, which would mean about 16 babies per year here in the United States. And AGAT is even less rare, or even more rare, excuse me. However, it's hard to tell what that true rate of occurrence is until it's on newborn screening. Our feeling is that the rate of occurrence is much larger, but again, how do you know until you start testing, right? So there's been some newborn screening in other parts of the world, including parts of Europe, such as in Austria and the Netherlands. The Netherlands, and this is an ever-changing thing. We are just getting updates every day. I talked with Dr. Solomons earlier. I'm like, where are we at with the Netherlands? She says, okay, so the Ministry of Health has approved newborn screening, but it's a debate of how it will be completed. So, and I know that Dr. Solomons could probably speak more on that, but currently British Columbia, Canada, is screening for Gant, headed by our SMAB member, Sylvia Stockler, who couldn't be here today. And in part of Australia. And for the past several years now, Australia has been screening. However, as of a year or two ago, they had screened over 1 million babies and still have not found that one. A bit of history in Austria. Austria was also testing, and they came very close to diagnosing a Gant baby, but unfortunately they tried to do a confirmatory test with urine. And they received a false negative because the creatinine ratio is still high enough, elevated enough, that they missed that. They sent that baby home. 2 years later, that baby presented with epilepsy, and they came back and they said, oh, yep, has Gant. So had they done that blood test, we would have had probably that on newborn screening today. Yes, we have presented that to the ACHDNC. We went back and we said, hey, what about this one? And they said, no, because technically it was considered a false negative. So, what do? We go back again and again, each time presenting new evidence to support the nomination. In one of those meetings, you may remember we asked for some of you to send your pictures in of your children. And one by one, Heidi held up that picture, and she said the name of your child, where they were, and I will say that you could have heard, like now, a pin drop in that room. It made it real. We needed those pictures, we needed those children, and you provided that with us, and that's where we need all of you. This is a picture of Heidi and I along Dr. Longo, head of our Scientific Medical Advisory Board, and Dr. Pasquale, who is head of AREP Labs for the state of Utah. This is one of the committee meetings not long ago, and part of what the ACHDNC recommends is that you form a multidisciplinary team to submit the nomination for a disorder to be considered. They're looking for a team to include researchers or clinicians or both that have the expertise on the condition that's being nominated. interested patients, parents, or individuals affected by the disorder, and of course, an advocacy or professional organization with the knowledge of issues relevant to newborn screening. I would like to mention that both Dr. Longo and Dr. Pasquale have been true champions, along with many of our medical advisory board members, in creatine deficiencies. Personally, I've had the opportunity to get to know Dr. Longo and Dr. Pasquale, and they take their personal time to fly around the country and speak and meet us at different meetings in New York, in DC, wherever we need them, and we're incredibly grateful for that. In matter of fact, Utah was the first state to put Gant on newborn screening. They have been screening for the last several years, but have not yet had that positive result. And I wanted to mention, and Dr. Longo could probably share with us, the rate of a false positive is so extremely low, 0.001%. Am I right there? Pretty there. So we know that it should be on there. So just this past fall, Glenda, who you all may have had an opportunity to meet, and her daughter Carly, who was not diagnosed until she was 9, was having anywhere up to 200 seizures per day. She was in a constant state of seizures. They were able to meet me out in Georgia to help present at the state's Department of Health. And it is not passed yet, but we are working on it in Georgia. But these stories from you, the community, are very impactful and necessary. We've been able to add Gant this past year to Michigan and to New York, and they will both be starting testing later on this year, which is extremely exciting. New York especially, because they have almost over about 400,000 births per year. So our chances are much greater of having that one true positive. Thanks to Laura Martin and her efforts in her home state of New York, she has been an incredible advocate for ACD. She's a mom of Gant child. You guys can see I get really emotional when I talk about this. And she's coincidentally a genetic counselor. So she talks about the incredible amount of guilt that she has, but she is stepping up to the plate and she is doing what she needs to do, and she is making a difference. So thank you, Laura. Our understanding, again, is that the Netherlands will be putting this on very soon. So our future is bright. We feel very confident that it's not an if, but a when, that we're going to get that one true positive. So, in closing, I want to tell you that I personally think this is one of the most proactive approaches that our society can do to help our children. If more disorders were screened, more would be identified. Pharmaceutical companies would be compelled to find a treatment or come up with a better one. I also think that there's a lot of hope with the sequencing that's being done these days. One day I think that we'll have a much more robust screening program. I hope that our newborn screening program will match the enthusiasm of the rare disease community. That will make the difference. We say that, the averages of a rare disease to be identified as an average of 7 years. I hope that it gets down to 7 days. I think it's possible. I think we have to work at it. I think we're willing to do that. So, with that being said, I want to say thank you all again for being here. We really appreciate it. The turnout's incredible. And I would now like to turn the rest of this presentation over to Dr. Nicola Longo. He is a professor of pediatrics and chief division of medical genetics at the University of Utah.
I want to thank all of the organization for creatine disorder for inviting me here, but especially for setting up this meeting. This is outstanding. I mean, you have been able to put together a group of people that basically has never been together before for the purpose of discussing disorder of creatine metabolism and transport. So what I want to do is a second, what is newborn screening? What can we do? What can we detect through newborn screening? So I'm going to skip a few slides because I'm a little bit behind. But the two diseases that could theoretically be identified by newborn screening are Gant Deficiency, which is the first disorder in the pathway for the synthesis of creatine. And what you see, these are 2 patients that we have tested in our lab. And what you see, these were diagnosed at about 20 years of age. How? By exome sequencing. I mean that people had no idea why these 2 young ladies were behind in development. They had intellectual disability. And the way to confirm the diagnosis is measuring the level of guanidinoacetate and creatine. And what you can see that guanidinoacetate is extremely low in them. And the second disease that we can detect by newborn screening is obviously Gant Deficiency, where the level of guanidinoacetate is way above the normal range. Creatine is also reduced, but we will see that creatine is not a very good primary marker. In general, with newborn screening, we can identify very nicely what is high. It is much harder to identify what it is low. So in other words, getting exactly the patient with Gant deficiency, the one who have level of 0, would be hard to do. It is possible, but again, it would be hard to do because setting a lower end of normal can be problematic. Now, what is newborn screening? So newborn screening wants to identify early people for which intervention can prevent disability or mortality. And obviously, it is very clear to all of you that the earliest to identify children with either Gant or Gant deficiency, the more likely we are to have an impact on the development of their brain. And obviously, this applies also to children with creatine transporter deficiency. The problem, we still do not have a therapy which is effective 100% of the time. If we did, then yes, even there, it would be ideal to identify them early on. And there have been criteria that have been devised to identify which conditions are amenable to newborn screening, mostly that we know a little bit about the condition, the morbidity, the mortality, the natural history, and then that there is a test which is reliable, that there is a treatment available, and also that we can evaluate the screening program itself in terms of cost effectiveness. And quite honestly, for Gant deficiency, all of this sounds very good because, obviously, it is among the diseases that we screen, probably the closest we have to PKU. PKU, phenylketonuria, is the first disease that was screened and the one for which the cost-benefit ratio is the most. So what I'm going to do is to explain in a moment how we did to develop the screening program. This was developed by Dr. Pasquali, obviously, not by myself. But we try to include this test with the routine newborn screening. What does it mean? It means that in dollar cents, you had a cost of about 20 cents or less to the existing newborn screening. And 20 cents is not very much. The reason is that this is completely integrated in the existing newborn screening. And that was what took some work to set this up. So it is measured with all of the other analytes as part of the standard newborn screening. And in Utah, we do 2 newborn screening. One which is collected usually at 1 day of age, and the second one which is collected between 7 and 14 days of age. And to establish if the method worked, we collected blood spot about half and half were less than 7 days and half were after 7 days. And then we had blood spots from patients with Gant deficiency collected at different ages. And we wanted especially, in addition to do the feasibility of the newborn screening, to evaluate the false positive rate. So false positive rate means that you have a child that seems positive, but so you have to call the family to get additional samples. So the family is very alarmed because, obviously you get called, you have a perfectly beautiful baby, and you get told that your baby might have a disease that the baby does not have. So that's what we do not like to do. And then starting to develop what it is called a second-tier testing. What is a second-tier testing? So when babies are born, we collect a blood spot. And then the baby goes home from the hospital. So what we do the newborn screening on the blood spot, but then we do a second-tier test on the same blood spot if that blood spot tests positive. So this is called second-tier testing that utilizes a different methodology from the one used in the original screening. So in this way, we can refine the result of the testing. So what happened to guanidino acetate and to creatine as we look to normal population and to the patient with Gant deficiency? As you can see, Gant deficiency patients are the ones who have the black square, and normal population is the one with the open circle. The guanidino acetate is always relatively low in the normal population, and it is much higher in all patients with Gant deficiency, irrespectively of age after birth. With creatine, what you see a different behavior. So creatine at birth is completely normal in patients with Gant deficiency. Why? Because creatine is transferred from the mom to the baby with the placenta. Obviously, if the mom doesn't have Gant deficiency, the creatine level in the mom will be the same creatine level in the baby and will be perfectly normal. So we cannot rely on creatine to identify these children. But if you look at just after 15 days of age, the level of creatine drops below the normal range. So basically, it takes some time for creatine to drop below normal in baby with Gant deficiency, simply because they start with a big level of creatine early on. Now, the way to determine which one is positive and which one is negative, so what we decided was the best approach is, number one, define a level of guanidino acetate that was around 2 point something, and the second thing, to establish a ratio between guanidino acetate and creatine. So if we plot the ratio between guanidino acetate and creatine and the guanidino acetate absolute value, we only have the Gant patient here with a few controls. So these are the false positives that we identify. Now, are these true false positive? No, because what we decided to do is to do the second-tier testing. And the second-tier testing, what it is a different type of test from the testing using the screening. What does it mean? When we do newborn screening, we need to test about 1,000 blood spots per day. So if something lasts 3 minutes per run, it's too long. We cannot take 3 minutes to analyze a sample. We need a test that takes 1 minute or less, because to test 1,000 babies a day, you need to really be fast. Obviously, this test is fast, but not very accurate. It only identifies the patient at risk of being abnormal for the analyte that you test. So the second-tier testing, it takes a little bit longer time. It involves a chromatographic separation of creatinine, guanidino acetate, and creatine. We will leucine be used as the internal standard. But this chromatographic separation can distinguish guanidino acetate from all interfering compounds. Now, what happens if we insert that one? So first of all, in the first set of 10,000 blood spots, we identify 0 false positive after the second-tier testing. All the patients were identified correctly. All the unaffected people were correctly identified. So there were no false positive. And obviously, this was very promising to start screening. And then in Utah, we had the opportunity to introduce newborn screening because we were able to talk to our state, and with the help of Heidi, who is here, and she has been a great advocate for newborn screening, we proposed the newborn screening as it is today. So we do the screening. If it is normal, we don't do a follow-up. If it is abnormal, we do the second-tier testing, again, without calling the family. And then if it is normal, we call out normal. If it is abnormal, then we obtain a confirmatory test. Now, this obviously has required getting involved all of the community, getting involved the physician, the testing laboratory, and basically doing the test for free. And what are the results? So we started on June 1, 2015, and the screening is for all children born in Utah. And so far, we have screened 139,000 newborn, And the false positive rate is basically 1 of these 139,000, which is 0.0007%. So the testing is highly effective. We are also looking for low level of guanidino acetate to see if we can identify children with with Gant deficiency. We still have not found a baby. But we obviously have tried to convince other states to join our state into testing more babies. We only have 55,000 births. And it is my understanding that New York might start at the beginning of October of this year to screen all babies for Gant deficiency. Again, the first time that we identify a baby, obviously the condition will be adequate for the RASP, and obviously if the RASP approve it, everybody will become familiar with disorder of creatine metabolism. Now I can tell you most pediatricians and many geneticists are still not familiar with this condition. They do not know which test to order to confirm or exclude the diagnosis, and they do not know how to treat this condition. If it is a part of the newborn screening panel, that completely changes the picture. So, and obviously, these data demonstrate that a newborn screening for Gant deficiency is feasible with low false positive result and can be included with minimal added cost. Just one word about the screening in Australia. They have not identified any positive case, but their cutoff is more than twice our cutoff. And the reason that they use a high cutoff is because without the second-tier testing, they would have too many false positives to call. So that it is why they use such a high cutoff. But using a high cutoff, you can miss quite a few cases of Gant deficiency. So I hope that now that New York State will join the rank, we will be able to identify a child with Gant deficiency relatively quickly and then expand the knowledge of physicians about a disorder of creatine metabolism and transport. I want to thank Kim for being to all of the meetings and being so supportive of us, but also pushing hard to include this condition for newborn screening at the national level. Thank you, Kim. Any question for Kim or myself? Yes.
Probably better for Kim, but with the lack of general knowledge out there, is there any advantage or any thought to advertising to the public?
So the way that we have been doing, we have been trying to include education about creatine deficiency, at least at the genetic meeting. So geneticists start becoming more and more interested and knowledgeable about this condition. Neurologists are really the one who would benefit the most from this education. Many neurologists are interested in them, but Dr. Tom DeGraw is not, and Dr. Denise Morita, who is also here, they are not the exact representation of all of the neurologists. I wish all of them were like them. I have to say that there are many like them, but not all of them. I think that would be, I would say, the next logical step to try to advertise more the disease to our neurologists, simply because many of the children have been diagnosed by neurologists.
Just a quick follow-up is most of the people here have been diagnosed after they've individually pushed their doctors for testing. So my question is more around, should we be advertising billboards, commercials, those types of things to get parents to push for kids who might need the screening?
It wouldn't hurt.
Well, and the point is that it's 20 cents a test. It's not a big deal. But then after newborn screening, how much more are parents going to have to spend? So, we're looking at how we can spread the word as quickly as possible to as many of the professionals as possible who will be able to implement it and at least know what we're looking for.
So to be honest with you, the best thing that can happen is having really the addition to the newborn screening panel, because this really would increase the knowledge at the national level. And if you do something which is mandated, then people will do it. Otherwise, people here don't. Yes?
Would you venture to give us how undiagnosed do you think this is? As far as, seeing the way kids are, seeing the way other kids, you know, who have labels, ID, autism, you know, CP, things like that. How undiagnosed do you think this is, and how many, I mean, it's astonishing to me to see some of the similarities of other, you know, diagnoses, and to not have these kids who are going in for, you know, I don't know if a MRS is something that genetics or neurologists would just assume to order, but how undiagnosed do you think this is?
I think that the vast majority of children with brain creatine deficiency syndrome are undiagnosed. So here, this is the tip of the iceberg. And the problem is that there is no specific defining factor that makes you think that a child has brain creatine deficiency syndrome. Some of them have low creatinine level in blood. Many children who do not eat enough have low creatinine level in blood. So we put weight up to a point to that one. One of the things that we have been fighting that we have been very successful with our hospital has been that our neurologists add magnetic resonance spectroscopy to the evaluation of almost any child with intellectual disability or delays in development. That works very well. But you know, most of the reality is that the radiologist and the machine cost money. And if you don't pay for it, they will not do it. And that it is a big issue, and that it is what we need to fight. So I think that, you know, if we could expand the involvement of the neurologist in this disease to convince almost everybody to do the mass spectroscopy and the neurologist to think about this disease, that would be the direction to go in the short term. Newborn screening would be the next one.